Good afternoon. My name is Lisa Mrozinski. I am the head of Total Rewards at Baird. So if anybody, hopefully everybody knows who Baird is in this room, but we are a financial services company headquartered here in Wisconsin, although we've grown quite a bit in the last 20 years since I've been at Baird and have been a part of the business healthcare group. I'm convinced Jeff asked me to moderate this panel so he didn't have to pay somebody to do this because I'm setting expectations right now. I'm an amateur, so little grace would be very much welcome. I just wanted to say just a few words before I get into our distinguished panel here, but our prior CEO, Paul Purcell, who was one of the founding members, he was a visionary himself related to healthcare. He didn't even live in the state of Wisconsin, but he was very committed to this organization. And he always talked about how, we needed this organization to continue to do business in the state of Wisconsin. If this organization had not come along, I'm not sure Baird would have been able to continue to do that. So incredibly grateful to him. We rely on the BHCG as part of our healthcare strategy, and that centers around a little bit what Ashok just talked about, an investment in our people versus an expense. And that also centers around accessibility, affordability, and well-being. And I think that's what we're all trying to do as employers in order to show that we care for our associates and employees. So thank you all for having me be part of this be the moderator for this panel. I have a quick introduction. As I said, I'm an amateur, so I have to read my prepared remarks. But then we're going to go and ask some questions, and please feel free to think of your questions as we're kind of talking through this. But helping to drive positive change in the healthcare marketplace has really been something that has been a key tenet for BHCG. And one area of focus has been the support of the advanced primary care model. So our BHCG initiatives have strongly endorsed the value between having effective primary care relationships between patients and primary care teams. Not necessarily the employer, the patient and the primary care team is what we're committed to. And then we went further in designing the high performance solution, to sit on top of that high performance kind of chassis, providing employer health plan benefit alignment rather than lip service. So we're really committed to this. And the idea that having a clinical guide, someone who is knowledgeable and connected to the patient, will result in better clinical outcomes for that patient as well as lower costs for the employer. We believe the effort is succeeding as the BHCG. We also believe that it is shared interests of the employer community, so it not only impacts our individual organizations, but impacts our community as a whole. Families are impacted. Healthcare provider community is also impacted to help us execute on this model. We also believe in the effective use of data and metrics to ensure accountability, and that also includes employers' strong commitment to this model. So today, we have this distinguished panel of guests and clinical leaders to discuss this important topic about primary care, and really to explore how this continues to develop in the future and how we continue to optimize this model for the care of our employees and our community. So I'm going to have each panelist introduce themselves, and if you could just give kind of a quick introduction about who you are and how your organization or what the emphasis or the impact of this provision of primary care is related to your organization.
Hi there, I'm Patty Golden. I'm the Chief Medical Officer for Ascension with the medical group. I am a family practitioner by background. I've been practicing for over 20 years in the Milwaukee area. First, I want to say thank you to all of you who have really spearheaded that drive for primary care, being at the center of a patient's experience. For me, as a family practitioner, it is the most humbling and rewarding job I could ever ask for. To have a patient, their family, trust me to be at the helm of their healthcare journey is again, it's so humbling to be part of that with them. And so for you guys to invest in creating a stronger primary care base is just an honor to be amongst all of you.
Good afternoon. I'm Paul Pritchard, Vice President and Chief of Quality from Prevea Health, which is located primarily in eastern Wisconsin and northeastern Wisconsin. I used to say Green Bay, but the team's struggling a little bit this year, so that source of pride has gone out the window. I'm an internist by training. I still have a small practice in addition to my administrative duties. That practice includes just regular people from all walks of life and a cystic fibrosis population I take care of. So I cut my teeth a lot on population health and things of that nature from that group of individuals. And I couldn't have said it better in terms of the primary care emphasis of BHCG. One of the things I've noticed after I got into administration is one of the first things I did, because my panel got a little smaller. Patients knew I wasn't going to be as available as much as I was before. So the ones that stuck with me actually kind of liked me, which was shocking to begin with. But, you know, I increased my visit times because I don't have as many people. I can sit around and talk to them a little bit more. My enjoyment in my practice went up tremendously after I started being able to get to know some of these people. I mean, in the past, and I feel for my partners that are still kind of in the grind, you know, you had time frames, you had to get through things. Now I can sit back and ask them, what are your goals? What are your ambitions? What do you want at end of life care? What are the things that scare you? So as a primary care doc, that's what I went into it for. And like a lot of us, I got lost in some of the shuffle of corporate medicine and things of that nature. So the emphasis of BHCG, putting it back on the primary care docs, is, for me, very rewarding and very important.
Thanks, Paul. Mark Lotus. I'm an internist as well as a pediatrician. Been with Frederick Medical College of Wisconsin for a better part of 20 years. Paul and I go back to residency, so we were residency mates back in the day.
Don't ask us when.
So nice to be on the stage with you, Paul. First, I want to thank the business group, the business healthcare group, for entrusting the lives of your family members and yourselves to us for all these years. I think that trickles down to all your employees that view our health system and the services we provide as a front door for primary care as well as for high-end specialty care in the region. We could not provide the services we provide today or had the growth that we've had if it were not for the partnership and the trust that you've had in us and the services we provide. For about 15 years before I was in my population health role for the enterprise, I was growing the primary care base for Frederick Medical College throughout the region. When I started, we only had 2 or 3 clinics right around the main academic campus, and now we've got buildings, kind of throughout the region. The vision for this was that we really fundamentally wanted to be a force in driving health and wellness amongst our communities. And we knew the only way to really do that was to have an accessible front door. What we've seen over the last few years, though, is that, when I went into primary care and that fee-for-service model was all around kind of office visits and managing patients during those episodes. But increasingly, our focus on population-based health has really taken us away from that synchronous environment to a more asynchronous environment where we're trying to have a real understanding for which of our patients are at highest risk for disease, which of our patients may not have had their vaccinations done or their preventative screenings done and all the rest. And then layering on a whole nother layer of support and outreach. And that takes a huge team, right? It goes beyond just a single primary care physician with a single patient. It goes to how you layer on medical assistants and nurses and pharmacists and social workers and behavioral health specialists. And so one of our big focuses on the primary care base is how we build those teams, how we build central processes to be able to engage patients and the populations, how we understand who's at highest risk and provide a little bit more service, a little bit more attention, and trying to drive patients to the best possible health we can. So great to be here with you today.
Hi, Wayne Jenkins. I'm the Chief Medical Officer for Centivo. I started out a very long way from primary care as a radiation oncologist, worked for MD Anderson, a large cancer center, but I became very interested in seeing a lot of patients whose health care was unaffordable. And so went back to school, did a Master of Public Health, and got very interested in how we could look at making care more affordable. So I was in a chief medical officer role in a health system in Florida, and then at Vanderbilt in Nashville, but really saying, how can we connect this to primary care? How do we create what you hear about these ACO models, clinically integrated networks? And so early into those advanced primary care models of how do we coordinate care, make it more affordable. But the thing that I started seeing is there was a missing piece. We would create all of these programs, and then no one would pay for it. And so when I met Ashok very early when he had this idea of starting this company, I said, okay, that's a really good idea. I want to go work on that. From can we get the employers and payers involved so we can advance this work we're doing? And so that was really where I came to this. And so of all the places we've been doing it in the country, this is as successful as it gets. And a lot of that is sort of the partnership. You really had good care set up in this area. And now it's how, as you as employers, advance that, make it affordable for people, have payment reform that can push these forward. So it's really been gratifying to work in this market and with these partners.
Thank you all. That was wonderful and very much aligned, I think, with what BHCG is trying to do too. So I'm going to start with a few questions, and then we'll have any other audience questions if you prefer, but I'm going to start with Dr. Golden. So BHCG's conjecture, supported by the data we have seen, indicates that a strong primary care relationship sits at the heart of effective healthcare. So having that medical home, as we've called it, where people actually know their physician, right? They see him in the grocery store and they're like, hi, instead of walking the other way, right? That's kind of what we're after. I think we believe Ascension is in agreement with that proposition, and you can dispute that if you choose. And we've heard from the provider community that there are certain elements necessary for success of that primary care model. What do you believe those elements are?
Yeah, we do agree.
Okay, good.
So we will not dispute that. And I think each of the panelists have touched a little bit on already what is really critical when we're looking at the best care possible for our patients. And it comes down to the relationship. It comes down to the relationship that you build with the physician and the care team providing the care to our patients. And with that, automatically, as you develop those relationships, you develop trust. And that trust is then what helps deliver the right care for the patient. And I loved how Paul talked about, just being able to spend that little extra time and listen to your patients. Each time you encounter them, you learn more about them. You learn more about their history, their beliefs, their needs. And so as we're developing those relationships, I know that we're going to be able to offer the right type of care for our patient. But the other thing that BHCG has done is that they've also incentivized their employees to come and see a primary care specialist. So one of the things that I think we all struggle with is there's a lot of access to get in for healthcare, whether it's through the doors of the emergency department, coming through the urgent cares. Yes, those are opportunities for patients, but a lot of times it's not the right place to go at that time. And so, again, when you have those relationships that's where they know the first thing they're going to want to call Paul. They're going to want to call their primary care physician and ask them, what is the right thing for me to do? And, with that comes the responsibility of us as health systems that we have back towards BHCG is that we're going to put high-quality providers in those positions. And so what that means is not only are they going to be making the right decisions, but they're also going to be driving the health outcomes for your employees. We've committed to making sure that we're providing everyone with all of the metrics. We've sat with the teams and come up with what are the goals, what are the outcomes, what are the best practices, and what are the quality metrics that are important to your associates and your employees. And those are the things that we're going to be constantly having conversations about. We're providing the data so that you guys know that we're doing what we've committed to say that we're doing, and also that we're all uniformly working together. So with that also comes our commitment to providing compassionate but very quick availability to our primary care physicians. So,
Great, thank
that's...
you. Dr. Lotus, primary care-centric models have sometimes been criticized as a subterfuge for simply maximizing revenue and getting people in the system, and really not addressing the patient and what their needs are. What would you have to say to those detractors that might have that opinion?
Well, I do think the old model of healthcare may have promoted some of this. And as we know, historically, payments to primary care has been significantly lower on average than what payments are for disease-based care to specialists or procedural-based care to specialists. I think this has put primary care in a position historically that they've been a bit of a loss leader with respect to the groups that they're in or the health systems they're in. And I think that has naturally, over many years, resulted in a look at what is the downstream impact? How can we justify that cost? What is that downstream impact on a fee-for-service basis? I think it's exactly the wrong, view. I think our contemporary view of primary care is one that is going to promote the health and wellness of individuals, that's going to result in greater preventative care and early detection of disease. It should come to no surprise that if you have your mammograms regularly, that women that do that on a regular basis are likely to be, if they are diagnosed at an earlier stage of the disease and are more likely to cure at a lower cost and a healthier lifespan. And you can say the same things for preventative immunizations and good care of chronic disease. So that's all in the wheelhouse of primary care. I am a proponent of really looking to a future model where at least that primary care base could be paid on a per member per month or on a more of a capitated or fixed basis for the work that they're doing. It would allow us to take care of a lot more patients. Our providers in our system are spending still the majority of their time in office-based visits or virtual visits. It's really that interaction and that transaction and the documentation and the billing that gets them paid. In more progressive models where you've got more integrated health systems on that more fixed payments to primary care, they're spending a lot more time on things like texts with their patients, emails with their patients, contacts, and the statistics are those health systems are able to have each primary care physician have a much larger panel of patients they're managing as well. So there's an efficiency there, especially as we're in primary care shortages. So in short, I think, that philosophy that you mentioned, I think certainly I have not been immune to hearing that over my career, but I think it's exactly the wrong philosophy. And what we should be doing and what the focus is, I think, of every single one of the physicians in our group is to take the very best care for each of their patients, get them the best health outcomes, and prevent a lot of that downstream and subsequent utilization that would otherwise occur.
Yeah, and I'm sure we'll continue to have more discussions about your recommendations, so, or your thoughts on that. Dr. Pritchard, as part of the BHCG high-performance model, we have integrated data elements that ask our healthcare providers to do some more difficult things. The underlying data from the physician value study said that there is a substantial variation in the quality and cost effectiveness of physicians in Wisconsin. And we as BHCG employers kind of made that tough decision to say until the underperforming PCPs can raise their performance to serve as the patient's clinical guide, that they would not, serve be in the network. We know this was a difficult ask, but you also know it's an important element to drive change for us within the Wisconsin healthcare landscape. What are your thoughts and reactions to that approach?
Well, the first reaction is always denial. You deny the results. But once you get beyond that, I think many physicians, especially in our group, are responsive to data. None of us went to school to be the worst doctor. We don't go to work on a daily basis to provide poor care. We took an oath to do the exact opposite. But, I believe, my personal opinion is a lot of what happens in our organization, I don't know about other organizations, is you've got people that trained in the 80s, you've got people that trained in the 90s, you've got people that trained in the early 2000s at different places. They were all taught different ways to do things. They were all taught different methodologies, different importance on certain things. The one thing that was consistent, though, is that patient sitting across the table from you is your responsibility. Don't mess it up. And so when you get a provider into a situation, a clinical situation, they're going to fall back on their training. And so unless you're showing them accurate, timely, actionable data that says, hey, you're not doing as well as some of your other peers, their likelihood of changing is probably not going to be very high. You have to be able to show them this is what's happening, this is how we think we can do better as an organization. And we've had a couple of examples of that in our own group so far. We looked at a surgical specialty, we evaluated the three of them, there was three of them, and there was a cost difference for us of $1,300 to provide a particular service with no difference in the outcome. And you go back and you start talking to them about why do you do it this way? Why do you do it this way? And orthopedic surgery is a perfect example because they all have different vendors that they've used over the years. Why do you use this Stryker product versus something else? Because that's the way I was taught. So you have to really kind of go back and show them the data, not only from quality but also from cost perspectives. And sometimes that's a difficult ask unless you have, like I said, the data sitting in front of you. So that's where the BHCG information is helpful for me to go back to my partners and say, hey, we've got a problem here. We've got to be able to adjust, be able to provide a valuable service to the people that we're providing care for. And by value, I mean high quality, low cost. And that's not always easy. I mean, I'm sure you guys got examples of surgeons that still want you to do a battery of lab tests prior to a procedure on a 28-year-old who's healthy. And that's non-value added. Anything that's non-value added doesn't improve your outcome, is inefficient, and is an expense for either us or for you. And we've got to get rid of that.
Yeah, and we as employers want to be able to confidently say these are high-performing physicians. So, thank you.
We're highly competitive, and
Yeah,
so
that
it
works,
shows
right?
the data, and
Competition
yes.
works, that's great, yeah. Dr. Jenkins, you are now the Chief Medical Officer of a health plan, but for a long time we're on the dark side, right? What insights does your past experience bring you to this role at Centivo?
So I alluded to that, just seeing that tremendous cost pressure on patients. That was probably what initially what it was. And then going back to how do employers engage, because that's how so much of the healthcare is paid for. That was a big part of it. But really, when I always looked at it on the delivery side, as working with our primary care physicians, it was that access to care and engagement. And so, free primary care, and really getting people in. I was really, one of the things that's really worked well in this area is, I think Jeff showed the primary care visits going up, but in one of those slides it showed it was those wellness visits went well up. And so I think that engagement access without the financial impediments. And so when you see those wellness visits going up, the group here has done a really good job of engaging people early on. And where that's important is if you know your primary care team, your first visit isn't to the ER. Or if you engage people, you do that screening colonoscopy and you find that precancerous lesion. And that leads to all the good quality and cost results. So I would say my other side was looking at the payment side from a distance and saying, okay, here's the things that we need on this side. So when I would go meet with, say, primary care physicians or health system partners, I was always coming at like, hey, I know what it's like on your side. Here's how we need to do things differently, when we're on the payment side.
Okay, great, thank you. So for any of the panelists, this isn't a new concept, focusing on primary care. I think we've seen some of the results that, Centivo is producing related to that. So one simple question for all of you, why aren't more people doing this? Like, why aren't we all doing it?
Why aren't more people in the country doing it?
Yeah.
Now that one I
Yeah.
have an opinion about.
Oh, okay, great.
I mean, it's really remarkable, and I've talked, because, so when I was in Orlando, we did this direct deal with Disney. And Disney had 100,000 people, and I thought everyone was going to rush in and say, okay, now we'll do that, and they didn't. So I think, I think maybe, that word courage at the beginning is a lot of employers are just like, we don't really want to do this because somebody's going to complain somewhere. And so as I go around the country, where we're doing this in different markets, like, oh, we don't really want to rock the boat. And I'm like, well, look at how much, look at the problems your employers are having. So I think a lot of health systems, not all of them, but around the country, there's a lot that are wanting to design this way, but there's just this reticence to push it forward because of the fear of change.
Because they don't want to deal with the complaints.
Go ahead.
Yeah, so what's really interesting is even 20 months ago, I remember sitting down, my brother works for an organization who BHCG is supporting, and, the initial conversation that I had with him was about, well, I feel like I'm giving up my choice. Like, I want to have choices where I can go. And so the conversation I ended up having with him is I said, your employer is committed to finding you the best care possible. And again, we can talk about expenses, but it really comes down to you guys have made a commitment to making sure that your outcome is the best there possibly is. And so that choice really isn't as important as I think people think it is. And, again, when we're talking about show us the data, when you show patients, like, you are going to the high quality, we are going to do it in a cost-effective way. And I loved the slide that showed the cost to the patient is significantly lower. That's huge.
Mm-hmm. Yeah.
I think you really have to, when you ask that question, I'm kind of wondering which perspective are you looking at it from? If you're looking at it from the employee or the employer, why don't you do more of this? It's change, and you hit the nail on the head. I have a lot of patients that'll be like, well, I don't want to switch my provider that I've had for 20 years. Mm-hmm. Even if you show them a report that they may not be the greatest, they still believe in that provider because they have a relationship. If you look at it from the healthcare perspective, it's where the incentives are. I think it was Deming that said something along, your system will get what it's perfectly designed for the results it gets. We've been for so long, and Mark said this, been paid based off of volume, paid off of utilization, paid off of, those types of things. So for us to put the infrastructure in now, we have to be incentivized. We have to be involved in things like this. They're going to say, no, we need to switch the curve. We need to be able to put a different emphasis on how our systems get reimbursed. You were kind of hitting on that. So.
Yeah, I mean, I think historically too, just to build on that, in the 1980s, we saw the big rush to HMOs, right? And narrower networks and, primary care as gatekeeper model, right? And I think the pendulum swinging away from that in the 90s and the early 2000s to more indemnity of PPO plans really took us away from that. I think in some respect that de-emphasized maybe the importance of primary care. I don't know that primary care physicians necessarily like to be in